This Brotsurge lecture series is on peptic ulcer disease. Peptic ulcer disease are focal defects in the gastric or duodenal mucosa that can extend deeper. Peptic ulcer disease is one of the most common GI disorders in the United States, with a prevalence of about 2% and a lifetime prevalence of 10% that peaks at age 70. A variety of factors contribute to the development of peptic ulcer disease, although both duodenal and gastric ulcers are mainly caused, as you see, by H. pylori. This duodenal gastric. NSAID use is also another common pathway to form ulcers. Ultimately, though, the gastroduodenal mucosal barrier has to be injured to form an ulcer. Here's a chart of duodenal and gastric ulcer characteristics. What we do know about duodenal ulcer patients is that their acid outputs can be in the normal range. In terms of gastric ulcers, there are 5 different types of gastric ulcers, type 5 being NSAID-induced and type 3 having acid hypersecretion along with type 2. Here's what we know about NSAID use. It increases peptic ulcer disease 5-fold and GI bleed 2-fold. Here we will also review duodenal ulcers. They typically occur in younger patients, male greater than female, which is the same characteristic as gastric. Duodenal ulcers are more common. Basically, what you'll hear is that food relieves the pain, but it increases 2 to 3 hours after a meal. It wakens 2/3 of people from their sleep. This is different than gastric ulcer, where food increases pain. What you'll note on a history is that the pain is non-radiating, burning, and it comes from the epigastrium. What are the complications? The same as for gastric, and we will learn about the operations for them later on in this lecture. Bleeding, perforation, and obstruction. Bleeding, perforation, and obstruction for duodenal and gastric. Let's talk about gastric. What happens with gastric ulcerations is that the pain of a gastric ulcer more commonly occurs with eating and is less likely to awaken a patient at night. Other signs and symptoms include nausea, bloating, weight loss, and can have positive occult blood in their stool along with anemia. So food increases their pain. I've moved our chart along. I will still write duodenal ulceration here. Duodenal. And gastric, so we remember. Here's one thing I'm going to write about gastric. We need to biopsy gastric ulcers. Biopsy them, okay? Common complications, again, include bleeding, perforation, and obstruction. In bleeding patients, all patients should be started on IV PPIs and IV fluids. If they rebleed after any endoscopic measures, this is when you will need to take them to the OR, if they rebleed. Another common complication is obstruction. Due to duodenal and prepyloric ulcer disease, patients can present with non-bilious vomiting and have hypokalemic, hyperchloremic, metabolic alkalosis, and dehydration. Here's another one that I want you to remember, is Zollinger-Ellison disease. It is a gastrin-secreting cancer that results in acid hypersecretion in the stomach. The medical treatment of peptic ulcer disease is lifelong PPIs. The surgical treatment of peptic ulcer disease for perforation, obstruction, bleeding, and intractability, or basically non-healing, is the reason that we do surgery. What you should know is that anyone that has an obstruction, either found by endoscopy or an ulceration in a gastric ulcer, these need to be biopsied to rule out cancer. Here's what we need to know is that mainly an ulcer is oversown if there's bleeding. And then we should consider a vagotomy, which would decrease acid secretion, and it's basically some way of severing the vagus nerve. If we do a highly selective, which we see here, we ligate branches of the vagus nerve, and it decreases acid supply. Sometimes a PPI is just given instead. There are other procedures called vagotomy and drainage procedures. Generally, you need a drainage procedure to allow the contents to empty. And by this we mean vagotomy and pyloroplasty, which I'll show you in a minute, or truncal vagotomy and gastrojejunostomy. Basically, the reason that the drainage procedure has to occur is because when you cut the vagal fibers, the pylorus cannot relax. The vagus actually provides relaxation to the pylorus, and if you cut them, the pylorus won't open. Here is what we would consider one of the procedures called a pyloroplasty, where an incision is made. Change the color. An incision is made along the pylorus in such fashion, and then it's sutured in the opposite direction to make a larger passageway, and this is the end result. Here is an example of a gastrojejunostomy where part of the stomach was the end result. Here is an example of a gastrojejunostomy where part of the stomach was excised due to the ulcer and then sewn directly to the jejunum. Following an antrectomy, excision of part of the stomach due to ulcer disease, there has to be a reestablished GI continuity. And the way that is done is with a Billroth 1 or a Billroth 2. Here we can see a Billroth 1 because the stomach is attached. The stomach is attached directly to the duodenum here. It's excised, and this we call a Billroth 1. Another surgical procedure done for peptic ulcer disease is something called the Roux-en-Y. And basically what this is a surgical procedure in which the stomach is resected, and it is connected further down the digestive tract to the small intestine to create a Y-shaped configuration. And the intestine is also, a second anastomosis is created further on, as you can see here. A Billroth 2 similarly involves connecting the stomach to a remaining portion of the small intestine with one anastomosis. And here's a good example of that. Here's a little summary of bleeding ulcer versus perforated ulcer. In a bleeding ulcer, if it's duodenal, you want to oversew. If it's difficult ulcer to oversew and do truncal vagotomy and drainage, if they rebleed, you need to perform an antrectomy. For a gastric ulcer, you want to oversew and biopsy. If they rebleed, you need to do a distal gastrectomy. For a perforated ulcer, if the patient is unstable and it's duodenal, you want to patch. If it's gastric, patch and biopsy. If the patient is not stable, you want to do, for duodenal ulcer, do a patch and highly selective vagotomy, or patch and vagotomy and drainage procedure. If it's a gastric ulcer and they're unstable, a wedge resection and a truncal vagotomy and drainage procedure. Here you see basically the difference between a Billroth 2 and a Roux-en-Y. And here's a little chart of what we do when, if it's bleeding and it's duodenal, oversew. If it's gastric, oversew and biopsy. If it's perforated, patch. If it's gastric, patch and biopsy. If it's obstructed, a vagotomy and some sort of resection and drainage procedure, and of course biopsy if it's gastric. If it's not healing, a highly selective vagotomy and potentially resection and some sort of drainage procedure is necessary. A few more tidbits of information. What do we treat H. pylori with? It's PPI and bismuth, metronidazole, tetracycline. And just to review, the indications for surgery for gastric ulcer is intractability, hemorrhage, obstruction, and perforation. The surgery indicated for duodenal ulcers is intractability, hemorrhage, obstruction, and perforation. The artery that could be involved in duodenal ulcers is gastroduodenal artery. Remember that if you do a truncal vagotomy, then you would want to do some type of drainage procedure like a pyloroplasty. If there is some type of perforation, you want to patch and potentially do a vagotomy, but then do a drainage procedure. If it comes back and it is intractable, then a highly selective vagotomy and potential pyloroplasty.